Welcome to Board Pearls. This is episode 2 of 4 of the Liver Tumors and Transplant chapter in the Liver Disease module. This episode is Hepatocellular carcinoma, from who gets surveilled through how a surveillance finding becomes a diagnosis and how that diagnosis picks a treatment. HCC begins with surveillance for one reason. The only way to deliver a curative treatment is to find the tumor while the patient still qualifies for one. The current recommendation is surveillance in every patient with Child-Pugh A or B cirrhosis, whatever the cause, including patients whose hepatitis C was cured, because the cirrhotic liver stays at risk even after the virus is gone. Child-Pugh C cirrhosis gets surveilled only when the patient is a transplant candidate, and that cutoff is pure logic. If liver function is too poor for any HCC treatment short of transplant, then finding a tumor in a non-transplant candidate changes nothing, so you only surveil where a finding can change what you do. Non-cirrhotic chronic hepatitis B gets surveilled when it hits one of several risk triggers, because hepatitis B causes cancer directly through viral oncogenesis even without cirrhosis, and those triggers are Asian men over 40, Asian women over 50, people of African ancestry at a younger age, a family history of HCC, a viral load over 200,000 international units per milliliter, HBe-Ag positive status prior HCC, or a Page B score of 10 or higher on long-term antiviral therapy with hepatitis D co-infection surveilled. The modality is a right upper quadrant ultrasound with alpha-fetoprotein every 6 months, and the 6-month interval is set to the tumor's doubling time, short enough to catch lesions while they're still within the size cutoffs that allow a curative treatment, which is the entire point. A yearly interval would let too many tumors outgrow those cutoffs between scans. The role of the AFP is worth understanding because it shifted from optional to a recommended add-on. Adding it to ultrasound catches meaningfully more cancers than ultrasound alone, and that gain is worth the false positives when it's paired with imaging. But AFP is never a standalone test, because both its sensitivity and specificity are weak. A normal value doesn't exclude HCC, since some tumors don't secrete it, and a mildly high value doesn't establish it, since hepatitis flares and regeneration also raise it. The one setting where AFP carries diagnostic weight on its own is a value over 200 nanograms per milliliter, together with arterial enhancement on imaging, because concentrations that high are uncommon in benign disease, so that combination strongly supports HCC even when the imaging is otherwise equivocal. 2 practical wrinkles. Severe obesity or heavy steatosis can make the ultrasound useless because sound doesn't penetrate, and then you substitute MRI or CT every 6 months. And the override that runs through the whole section is that a new liver lesion in any cirrhotic or any chronic hepatitis B patient is HCC until proven otherwise, even when the imaging features would look benign in a normal liver, because the pretest probability is high enough that reading a small lesion as a regenerative nodule or focal fat is the wrong move. The right move is to enter the diagnostic algorithm, which is LI-RADS. LI-RADS is what turns a surveillance finding into a decision. It grades cirrhotic liver lesions from 1, definitely benign, up to 5, definitely HCC, with 3 as indeterminate in between, plus 2 special categories, 1 for a mass that's malignant but not typical of HCC, and 1 for tumor growing inside a vein. These categories aren't arbitrary. They track the imaging features that reflect HCC biology. The 5 category is the diagnostic one, and it requires a lesion 1 centimeter or larger with arterial phase hyperenhancement plus at least 1 major feature, where the major features are washout in the delayed or portal venous phase, an enhancing capsule, or threshold growth defined as a 50% or greater increase within 6 months. When those are met in a cirrhotic liver, that's a diagnosis of HCC without biopsy, because the picture is essentially specific and a biopsy would only add tumor seeding risk. Each of those features has a mechanism worth carrying. The arterial hyperenhancement is the tumor building its own arterial blood supply through angiogenesis, so it lights up brightly in the arterial phase, while the normal liver, still fed mostly by the portal vein, hasn't enhanced yet. The washout is the lesion emptying quickly through leaky abnormal tumor vessels, while the surrounding liver fills in during the portal phase, so the lesion goes relatively dark against a brightening background. And the enhancing capsule is the fibrous rim of compressed liver that a growing HCC pushes against, which takes up contrast. The 4 category is probably HCC missing 1 feature, managed with short-interval imaging or biopsy depending on the patient. The 3 category is indeterminate and rescanned in 3 to 6 months, because lesions here can regress or slowly declare themselves, and the weight lets them. The malignant but not HCC category exists to force a different path: rim, arterial enhancement, peripheral washout, and a targetoid look point toward intrahepatic cholangiocarcinoma, or a mixed tumor rather than HCC, and you biopsy these because management diverges sharply, since intrahepatic cholangiocarcinoma over 2 centimeters is a transplant contraindication, and its drug therapy differs. So a cirrhotic with a lesion showing rim enhancement and peripheral washout is the classic case where reading it as HCC is exactly wrong, and the rim pattern is the tip-off. The tumor in vein category is almost always HCC that has invaded the portal vein, identified by an arterially enhancing thrombus, and that enhancement is what separates tumor thrombus from bland clot, because bland clot has no blood supply and doesn't enhance, while tumor thrombus carries its own arterial feeders and lights up. The practical consequence is that tumor thrombus is metastatic disease for transplant purposes. It takes the patient out of the transplant criteria, and you don't anticoagulate it. Biopsy carries a small but real risk of seeding the needle tract, which is why you avoid it when the imaging is already diagnostic. But you do biopsy the malignant but not HCC lesions, cases where you need tissue for molecular testing before systemic therapy, and genuinely ambiguous lesions. Once you have a diagnosis, the treatment decision runs through the BCLC staging system, which combines tumor burden, liver function, and performance status, and each stage points to the treatment the underlying physiology will actually permit. The earliest stages are the curative ones: a single small lesion or up to 3 lesions, each at most 3 centimeters, with preserved function and good performance status. And here resection, ablation, and transplant are all possible, and the choice depends on the substrate. Resection is straightforward in a non-cirrhotic liver, including the hepatitis B cancers that arise without cirrhosis and are often resectable even when large, but resection in a cirrhotic is narrow because taking out liver mass can tip a portal hypertensive patient into failure, so you require a normal bilirubin and a hepatic venous pressure gradient under 10, since a gradient over 10 signals the clinically significant portal hypertension that sets up postoperative decompensation. When resection is off the table, thermal ablation with radiofrequency or microwave substitutes for tumors typically under 3 centimeters, and the size limit matters because ablation only kills reliably within a defined zone, so larger tumors risk an incompletely treated margin, and proximity to a vessel causes a heat sink effect where flowing blood carries the thermal energy away and leaves viable tumor at the edge, so a small lesion in a bad surgical location or in a patient with marginal reserve is an ablation case rather than a resection case. Transplant is the treatment of choice for early HCC in the cirrhotic because it removes both the tumor and the cirrhotic liver that keeps generating new tumors, and eligibility is defined by the Milan criteria: a single lesion at most 5 centimeters or up to 3 lesions each at most 3 centimeters, with no spread outside the liver and no macrovascular invasion, and that last exclusion follows directly from the tumor in vein teaching because tumor thrombus is metastatic disease. Within Milan, long-term survival after transplant is strong. The UCSF criteria widen the door a bit to a single lesion up to 6.5 centimeters, or 2 to 3 lesions with the largest up to 4.5 centimeters, and a total tumor diameter up to 8 centimeters. And a patient beyond Milan can be downstaged into Milan with locoregional therapy, followed by 3 to 6 months of imaging stability before listing. And that waiting period is deliberate biological selection, because a tumor that responds and stays quiet has biology unlikely to recur after transplant. The intermediate stage is multifocal disease beyond Milan without vascular invasion or spread, and it's treated with locoregional therapy, either chemoembolization or selective radioembolization delivered through the artery, both of which exploit the fact that HCC feeds preferentially off the hepatic artery, so catheter-directed delivery hits the tumor hard while sparing the portal-fed normal liver, repeated as needed. Response is graded by looking at how much tumor still enhances rather than by total size, because successful therapy produces necrosis without immediately shrinking the mass, so viable enhancing tumor is the real readout. The advanced stage is macrovascular invasion or metastases with preserved liver function, and it's systemic, with first-line therapy being atezolizumab plus bevacizumab, a PD-L1 inhibitor paired with an anti-VEGF antibody that outperformed the old tyrosine kinase inhibitor on survival. The catch is bevacizumab's bleeding risk. Because it blocks the VEGF-driven angiogenesis that also maintains vascular healing, it raises the risk of variceal bleeding in a cirrhotic, so the rule is a mandatory upper endoscopy within 6 months before starting it, with any high-risk varices treated first, and that endoscopy requirement is the direct practical consequence of the drug's mechanism and a high-yield testing pattern. When bevacizumab is contraindicated by uncontrolled varices, recent bleeding, or recent surgery, the alternative is the checkpoint combination of durvalumab plus tremelimumab, and lenvatinib or sorafenib remain options when checkpoint inhibitors themselves are contraindicated, for instance by autoimmune disease, with cabozantinib in the second line and ramucirumab for patients with an AFP over 400. The terminal stage, poor performance status, or Child-Pugh without a transplant option is best supportive care because the liver function and performance status rule out any tumor-directed treatment, and recognizing it protects the patient from futile therapy, so the patient with confirmed HCC, severe weight loss, poor performance status, and Child-Pugh with no transplant option is a hospice referral, not a chemoembolization. So the HCC arc holds together. Surveillance goes to every Child-Pugh A or B cirrhotic and to high-risk hepatitis B by ultrasound and AFP every 6 months, time to doubling time and curative size cutoffs. LI-RADS turns a surveillance finding into a diagnosis, with the definite category diagnostic by imaging alone, and the 2 special categories forcing biopsy or excluding transplant. And the staging system turns a diagnosis into a treatment, from resection and ablation through transplant within Milan to local regional therapy for intermediate disease and atezolizumab plus bevacizumab for advanced disease. Running under all of it is a single override. A new lesion in a cirrhotic or hepatitis B liver is HCC until proven otherwise, and the whole algorithm exists to prove or disprove it efficiently. The next episode turns to the other primary liver cancer, cholangiocarcinoma, where the organizing question is how the anatomy drives management. Intrahepatic disease behaves like a parenchymal tumor with a desmoplastic imaging look that distinguishes it from HCC. Perihilar disease at the duct confluence, the Klatskin tumors, is the one place transplant enters the picture through a neoadjuvant chemoradiation protocol, and distal disease behaves more like a pancreatic head tumor, with systemic therapy built on gemcitabine, cisplatin, and durvalumab, plus targeted agents for the molecular subsets. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 204 of chapter 24, and I'll see you in the next one.